Elevation of the head of the bed can be helpful, especially in patients who have nighttime reflux symptoms. Smoking is important, so smoking should be eliminated as it prolongs acid clearance by decreasing salivation and increases the frequency of reflux events through its synergistic actions of decreasing the LES pressure and increasing the number of straining events such as coughing and deep inspiration. Certain food items, namely caffeine-containing foods or fatty foods, should be avoided, and it's important to avoid meals about 3 hours before bedtime. This is an old slide, but it shows you that medical treatment hasn't changed much over the past years. It involves short-acting medications to treat heartburn, such as antacids, longer-acting medications, such as H2 receptor antagonists, and the proton pump inhibitors, which are the mainstay of treatment of acid reflux, and some other medications related to cisapride. Cisapride is no longer available because of side effects, but there are many medications considered in the same category as prokinetic agents. Surgical treatment remains a choice for GERD, and it mainly involves a surgery called fundoplication. It's mostly performed nowadays under laparoscopic guidance, so it's called laparoscopic fundoplication. Complications of GERD include esophagitis, stricture formation, bleeding, and the development of Barrett's esophagus. These endoscopic images are examples of esophagitis. In all of them, you can see the development of ulcerations at the level of the lower esophagus, just above the gastroesophageal junction. These ulcerations are caused by the acid exposure to the lower aspect of the esophagus. This endoscopic image shows you stricture formation. You can see that the lumen is narrow and there is some scar tissue or fibrosis, and this is caused by repeated inflammation and healing that is brought about by gastroesophageal reflux disease and esophagitis. This is an endoscopic image showing the bleeding that can be caused by esophagitis and esophageal ulcers that are brought about by the gastroesophageal reflux disease. This slide shows you Barrett's esophagus. Barrett's esophagus is an area of specialized intestinal metaplasia in the lower esophagus, and of course the diagnosis can be made by endoscopy and confirmed by biopsy. Major concern with the development of Barrett's esophagus is the subsequent development of adenocarcinoma of the esophagus. Normally, the squamocolumnar junction has to be at the same level of the gastroesophageal junction. In Barrett's esophagus, this squamocolumnar junction, or what we call endoscopically as the Z-line, moves upper in the esophagus. So as you can see on the right side of this slide, you can see that there is this development of the tongue of reddish-looking mucosa, which is mostly columnar, with specialized intestinal metaplasia in the lower aspect of the esophagus. One of the feared complications of Barrett's esophagus is the development of adenocarcinoma of the esophagus. As you can see in this image, on the left part, it's a pinkish mucosa of the esophagus, which is squamous. Below it, there is the reddish part, which is all Barrett's esophagus, and you can see clearly the cancer, the tumor, in the right side of the specimen. Chemical esophagitis can be caused by a multitude of things, including medications, what we refer to as pill esophagitis, corrosives, radiation, and few infections. This is an example of Candida esophagitis, that is esophagitis that is caused by infection with a fungus, Candida. It usually happens to immunocompromised patients. This is an example of CMV, cytomegalovirus esophagitis, that is esophagitis caused by an infection with a virus. This is an example of caustic injury, corrosive, such as strong alkalis, strong acids, detergents, bleaches, may produce massive damage to the esophagus. Finally, I'll be discussing motility disorders, and the most important motility disorder in the esophagus is achalasia. We'll be discussing pathophysiology, some clinical findings, special exams to be done to diagnose achalasia, and treatment options. The major pathologic changes in achalasia involve the loss of ganglion cells within the myenteric plexus, degeneration of vagus nerve, and abnormalities in the central vagal ganglia. Using the manometry, which is the test of choice for diagnosing achalasia, we can find three primary abnormalities, and these are absent peristalsis in the distal esophagus, increased resting tone of the LES, and the most important, absence or incomplete relaxation of the LES with swallows. Again, you can see these three features very clearly in this slide, and you can see, if you look at the pressure tracings inside the esophageal body, that the contraction is not moving, which means there is no peristalsis. If you follow the vertical line up down, the contractions are along the same vertical line, which means there is aperistalsis. There is also incomplete relaxation of the LES and occasionally LES hypertension. I will not be discussing the medical options in details, but it's important to know that there are drug options, medical treatments such as nitrates, calcium channel blockers, Botox injections, in addition to endoscopic and surgical treatments. Other motility disorders include diffuse esophageal spasm, hypertensive lower esophageal sphincter, ineffective esophageal motility, and scleroderma. This slide shows you an example of the diffuse esophageal spasm. It's a rare condition involving the smooth muscle portion of the esophagus. It manifests as chest pain and dysphagia. It's usually diagnosed by manometry, revealing high amplitude, repetitive, non-peristaltic contractions. This is an example of hypertensive LES, which is characterized by only a disorder in the LES where the resting pressure is high and there's exaggerated post-relaxation contraction. In scleroderma, which is a multisystem disorder characterized by fibrosis involving the skin and other organs, esophageal abnormality is based on patchy smooth muscle atrophy with fibrosis, which accounts for the decreased esophageal contractility and absence of resting LES tone. This results in acid reflux, damaging the lower esophagus, with heartburn being a common symptom. Miscellaneous diseases of the esophagus include esophageal varices, Mallory-Weiss tear, and structural anomalies. Esophageal varices are enlarged veins in the esophagus that are often due to obstructed blood flow through the portal vein, which carries blood from the intestine, pancreas, and spleen to the liver. And they show, as you can see on the lower part of this slide, as columns of vascular channels, mostly involving the lower aspect of the esophagus. Mallory-Weiss tear is a tear or laceration in the mucosal layer at the junction of the esophagus and the stomach. This is usually caused by severe vomiting and retching. And finally, Zenker's diverticulum, which occurs when a pouch of tissue forms where the pharynx meets the esophagus. It's a cervical diverticulum that is caused by the herniation of esophageal mucosa posteriorly between the cricopharyngeus muscle and the inferior pharyngeal constrictor muscles.